Hello, everybody. Welcome to the session Emergencies During Pregnancy and Labor. Usual, we announce that giving childbirth is a natural procedure done every day. The latest counting quotes 132,675,000 births per year. That means 4 per second. Imagine how many babies are born during our talk here. But as well, we all, every midwife and every doctor, know sometimes conditions and situations during natural process of giving childbirth can change in a second, and therefore bring very natural procedures to life-threatening danger for mothers-to-be and their babies. To deal with this is just part of being into obstetrics. But to prevent and to handle such situations is urgent, not only for our mothers, babies and their families, but as well in our professional and, to be honest, to our personal life as well, because every death or compromised mother or baby is a huge burden in our souls as well. The great impact of FIGO is to share experience and knowledge worldwide, and we will see that the emergency we talk about can occur in every second, in every part of the world. So it's a great honor to me to chair the following sessions, which will highlight maneuvers to prevent and to handle 4 of the most dangerous emergencies during pregnancy and labor. Let me warmly welcome our speakers from worldwide. Paulo Meande from Mexico will speak about placental abruption. He's member of the Maternal Mortality Committee of the Mexican Federation of Gynecology and Obstetrics and advisor of the Maternal Health Committee of the Latin America Federation of GNO. Jerry Visser from the Netherlands will follow with his talk about uterine rupture. Jerry is Emeritus Professor for Obstetrics in Utrecht, and he's member and past chair of FIGO's Committee for Safe Motherhood and Newborn Health. Bhaskar Paul from India will speak about shoulder dystocia. He's a senior consultant for gynecology and obstetrics in Calcutta. He's chair of the ACOG of India and vice president of the Indian Association of GNO. And the last talk will be given by Gabriel Orzanan from Brazil, who will speak about amnion fluid embolism and thromboembolism. He's professor for gynecology and obstetrics in Minas Gerais in Brazil and is vice president of the National Commission of Gynecology and Obstetrics in the Brazilian Federation of GNO. My co-chair, who could not be with us today, would be Dr. Escobar. Hello to her. And me, I'm Dr. Maike Manz from Germany. I'm senior consultant in obstetrics and perinatal medicine in Darmstadt in Germany and head of the section classical obstetrics in the German Confederation of GNO. You, the audience, can use the engaged button on your right upper left to pose some questions. And now we will start.
Hello, I'm Paulo Meath. I'm a gynecologist and obstetrician from San Luis Potosí, Mexico. And thanks for the invitation. It's an honor to me to be here. Today I want to talk about placental abruption. I am advisor of the Latin American Federation of Obstetricians and Gynecologists at the Maternal Health Committee. I have no conflict of interest. And I want to talk about placenta abruption and covariate uterus. The topic to address, the objectives is classification, diagnosis, conservative management, and it's very difficult to do that in 10 minutes, but I want to try to do my best. This is the classification. This is a partial separation. And the B is partial separations with apparent hemorrhage. And the third, the C, is complete separation with a lot of bleeding. There is some findings or symptoms according to the placenta abruption. So the bleeding, the uterine pain, the uterus tone, the fetal heart rate, shock, coagulation, levels of fibrinogen, and uterine infiltration. And in this table, we can check it. So I want to try to explain in mild, moderate, and severe. Grade 1 is not easy to recognize prepartum, and we have some ultrasound suggestive findings or in the fetal monitoring. This is the grade 1 where there is not very dangerous, but we can see all the fetal distress and the uterine polycystolia. And when we have bleeding, we have to suspect the placenta abruption. In grade 2, there is the classical symptoms, but not maternal fetal repercussions. We can see at the moderate, the bleeding is continuous, the uterine pain is intermittent, the uterus tone is hyperuterine tone, and fetal heart rate is acute fetal distress or absent of fetal heart rate. The shock is usually in grade 1 or 2. It depends the time of the bleeding and the volume of the bleeding. And coagulation is normal, fibrinogen normal, and uterine infiltration is just ecchymosis. In grade 3, we have that severe, that is heavy bleeding, and uterine pain is continuous, and uterus tone is goody, like a good. It's very important. So, and the fetal heart rate can be usually absent, and shock in grade 3, coagulation affected, fibrinogen is low, and uterine infiltration is the typical covaliar infiltration. This is the fetal grade 3. The grade 3 is fetal death, and it can be without coagulopathy or with coagulopathy. So when we have this non-common but very serious problem, it can be fetal repercussions, uterine repercussions, hemodynamic repercussions, hemostatic repercussions. So it is very severe disease during the pregnancy or during the labor of the patient. At the beginning, we have a hypertonic uterus, but when the placenta is coming out, we were going to have, after the blood uterine infiltration, we're going to have a uterine atony, a lot of bleeding, hemodynamic shock, and could be a coagulopathia. And the hemodynamic shock and coagulopathia depends on the volume and on the time of the abruption and bleeding. This is the typical histopathologic finding of uterine infiltration. So time is everything in these cases, because if we delay the treatment, we can have affection in or problem with the fibrin, and with the bleeding, an organ ischemia, because it could be coagulation impaired, but also thrombosis. And the most coagulation product, the affection, is the fibrin degradation products. So it's the most important marker. If we have a coagulopathy, it could be by degradation of the elements, by consumption, or delusional. The delusional is iatrogenic because sometimes we try to reverse the shock with infusion of a lot of crystalloid solutions. That's why we have to be very careful with this therapy. When we open the uterus, when we have the uterus inside, at the beginning, we can try to make a manual compression of the uterus, and it will respond. It depends on the grade, and we have to do that during the administration of the pharmacological therapy. But the best has to have the uterus out of the abdominal, because we can see the walls of the uterus, the front, the fundus, the posterior, and we can check the placenta if there is a findings of the abruption and the grade of abruption. When we start with the pharmacological drug, we have to start in these cases with carbetocin, 100 micrograms in bolus. The second line is oxytocin, 5 units, international units in bolus, and then in infusion. And the third line is misoprostol, 800 micrograms rectal route. And it takes a lot, it takes so much time, the misoprostol, but it's also, that's why it's the third line. And we do not use, or is not recommended, the use of ergonovin. At the time of the diagnosis, we have to give intravenous tranexamic acid, 1 gram, and calcium gluconate, 940 milligrams in infusion. Most of the vials is in 10 milliliters at 10%, and the doses is the 940 milligrams. Usually, the cochlear uterus seems equal to hysterectomy, but what happens with is the first pregnancy, or the mother wants more babies, we can try to do a conservative management. But first of all, we have to stop the bleeding. And there is a maneuver that is the abdominal compression, our aorta abdominal compression at the level of the bifurcation of the iliac, the common iliac arteries. We can do that with the hand, or we can do that with other methods like what we use, as you can see at your right. But we have to put a lot of pressure. That's why we put something just to protect the artery, like a sponge in the instrument. The conservative management, that is the most important part of this, is at the first we are going to have to try to have vascular arterial control, uterines, the Samson arteries, and uterovaric arteries at the beginning. And then we can also try to put an intrauterine balloon to do an intrinsic compression of the uterus, or we're going to show this video.
Yeah.
Where is a cochlear uterus? And the uterus looks like this because it has a balloon inside, because it was a abruption during the vaginal delivery. And we put the balloon, but the patient didn't respond to the balloon, so why we did a laparotomy. Also, when we have a C-section, we can try to do the Lynch sutures, or at the postpartum, we can try the Hyman sutures, that is a uterine compression sutures. At the right is the Hyman for the postpartum, and the left the Lynch suture and we can combine all of this vascular or arterial control, use of balloon, and after the balloon, we can put some uterine suture compressions, and then fill the balloon with liquid. So we can make a combination to try to have a successful in conservative management. The SMART bandage is described. I don't have any experience, but they describe some uterus necrosis. This bands is very common to use by the orthopedic doctors. When we do that, when we have a radical or when we have conservative management, it's always is mandatory. What is very, very important to put a drain just to check if the patient have intercavitary bleeding. Also, we put the non-pneumatic anti-shock garment, in the conservative treatment, where it has two functions. It's to derivate or send the blood from the lower extremities of the legs to the pre-charge in the uterus, increasing the cardiac output, and then we made an external compression. If we have a balloon inside and the uterine sutures compression, and also we have an external compression with this device, we can reverse the shock, and it can be useful to compression of the side of the placenta was there. We have to take a lot of care of hypothermia and coagulopathy and acidosis or hypocalcemia, because all these patients, we have to be very careful when we want to try and the conservative management in these cases, because the uterus can't respond, and we have to be very careful when we have a fibrinogen less than 200 milligrams by deciliter, or lactic acid more than 2 millimoles, or hypothermia less than 33 centigrade grades, or hypocalcemia less than 4 milligrams per deciliter, because it is associated with the lactic acid with anaerobiosis and all of the fibrinogen hypothermia and hypocalcemia with coagulopathy. And also, when we do that, a conservative treatment, lumbar management, has a high risk of bleeding post-surgery, so the patient has to be in intermediate intensive therapy or under survivals. The key message is that the abruption, the placenta abruption, is a very serious situation. We have to act immediately. There is a high probability of complications, and we have to be aware of coagulopathy and know that there is a conservative management in selected cases, and it depends of the maternal circumstances, and it depends of the medical skills and the place where we're going to manage these patients. Thank you very much.
Thank you very much, and good day to everyone. This presentation has been recorded on August 11 in Sicily, in the south of Italy, where it is at this moment 36 degrees Celsius. So let's hope the slides won't melt down. A presentation on uterine ruptures, 10 minutes only, in a session on emergencies during pregnancy and labor. I have no disclosures to make. In the past, uterine ruptures were mainly associated with prolonged labor, women laboring at home for 1 or 2 days and then being admitted to a hospital after a very long time, and to grande multiparae, as we call them, women who already had 4 or 5 earlier deliveries. However, at present, it's mainly a problem of women with a cesarean section scar. Why this change? Well, that's because there has been this enormous increase in the incidence of cesarean section. In between 1990 and 2015, there has been a threefold increase in the number of cesarean sections, with very high values in South America and also North America, Australia, etc. But also in other parts. Look here in North Africa, where it increased from 5% in 1990 to 25% nowadays in 2015. Cesarean section scars, uterine rupture. It seems that that might be a problem of the high-income countries, but that's not the case. Because if you look at the incidence of cesarean section for gross national income per capita, and we see here the very low-income countries, here are the very high-income countries, and you see there is indeed this increase in cesarean section, but the highest values, cesarean section incidence over 40%, occur nowadays in middle-income countries, Brazil, Chile, Colombia, Cuba, Ecuador, etc., but also Egypt, Georgia, Iran, Maldives, Mauritius, Turkey, etc. So highest incidence in middle-income countries, and that is a problem because their infrastructure might not be as good as that is in high-income countries. And we shouldn't forget that the risk after a cesarean section in subsequent pregnancy is much higher in low middle-income countries, given the large number of unattended deliveries, lack of transport, inadequate infrastructure in the hospitals, and poor quality of roads. More often, the fertility rate is generally high, so these women may have quite a few pregnancies following the one with a cesarean section. And cesarean sections are especially dangerous in some parts of Africa. This is direct morbidity and mortality following a cesarean section, African sites, and low-income sites in other parts of the world. And if you look at hysterectomy, unplanned hospitalization and maternal mortality rates, relative risk of 13 to 15% in Africa, whereas in other low-income countries, it is probably 2 to 2.5, the relative risk. So especially dangerous in Africa. The occurrence of a uterine rupture following a previous cesarean section in women during labor, it is about 0.4 to 1.2%. Relative risk for oxytocin is about 2. For prostaglandins, it's about 5, 4. Perinatal mortality, in case of uterine eruption in high-income countries, it's around 10%. So most babies will survive, but this percentage is likely to be much higher in low middle-income countries. And in high-income countries with adequate treatment and early diagnosis, hysterectomy is not often necessary, according to publication from my country, only in 5 to 6% of cases, but also this is probably much higher in other parts of the world. Trial of labor, vaginal birth after cesarean section, as compared to elective cesarean section. The number to treat is about 400 cesarean sections to prevent one uterine rupture. So, and that is why the trial of labor after a previous cesarean section is still favored by most of us, because the more cesarean section, so after the first one, also a second one and the third one, also the higher the incidence of complications. If we have a look at the incidence of placenta accreta, increta, and hysterectomy, in women without a previous cesarean section, it's 1 in 25,000. After 1, it's 1 in 500, 1 in 300, and after 3 and 4 cesarean section, it's already 1 in 10 to 20. And placenta increta, accreta, hysterectomy, these are very dangerous situations, regularly ending up in a maternal death. As to the risk of a uterine rupture, and that is the main message of this presentation, anticipation is of great importance. Well, we know the woman had a previous cesarean section. We also know that most ruptures occur during labor, more than 95%. So these women should labor and deliver in a hospital, and preferably in a hospital with a 24/7 presence of healthcare professionals. For instance, if you look at the Netherlands, perinatal mortality in case of uterine rupture during daytime is 0%. At nighttime, it is about 25%. So you need to have healthcare professionals there around the clock, not only obstetricians, but also anesthesiology. And these women should be monitored by cardiac tachography, since fetal heart rate changes are the most important indicator for a rupture. A more or less normal fetal heart rate pattern, rather suddenly changing to one with prolonged decelerations, is highly indicative of a uterine rupture. And if all of that is not possible, what do we do then? Well, then try to refer the patient to a hospital where that is possible, since women deserve optimal care also during the second pregnancy. And what about low-income countries and rural area? Well, preferably these women should be referred to a neighborhood of a hospital around 37 weeks to wait for contractions to occur. And to make your life and that of the woman easier, please prevent the first cesarean section. Since cesarean section not only increase the risk of uterine rupture, but also that of placenta accreta increta, and as a consequence of that of maternal death, they double the incidence of spontaneous preterm births and subsequent pregnancy, and are also in the index pregnancy associated with an increased maternal morbidity and mortality, and in immunological disturbances in the offspring, including that of childhood obesity. Publication in the Lancet, maternal mortality during and after a cesarean section, it's around 1% in these red areas in Africa, and the orange one, it is 0.5 to 1%. And also in the green areas, it is increased. Which are the most dangerous cesarean sections? Are the cesarean section during the second stage of labor. If you look at maternal death, first stage as compared to second stage of labor, you can see that the relative risk is about 10-fold higher. So please prevent the cesarean section during the second stage. And please, and that holds for many countries in Africa especially, reintroduce vaginal instrumental delivery. They result in a better direct maternal and fetal outcome, and they're also better for the future reproductive career of those women. Thank you very much for your attention.
Hello, everyone. I'm Bhaskar Pal from India, and I'll be speaking on shoulder dystocia. I have no disclosures. The problem with shoulder dystocia is that it is impossible to predict, as 50% happen in babies weighing less than 4 kilos and 70% happen in women with a normal progressive labor. It can be unilateral or bilateral. We have evidence that shoulder dystocia drills do improve outcome. As O'Leary said, there are no experts in the prevention and treatment of shoulder dystocia, only expert witnesses. How do we diagnose shoulder dystocia? The commonest one is the turtleneck sign, where the fetal cheeks and chin are pulled tightly against the perineum. The other things might be difficulty with delivery with the head and chin, failure of restitution of the fetal head, failure of the shoulders to descend, and head-body interval, delivery interval of more than 60 seconds. The mnemonic that you commonly follow is the helper one. H is call for help, E is episiotomy, L is the legs, P is the pressure. And in 90% cases, fortunately, the delivery is achieved by this stage. If that doesn't work, then we go on to E and R, which I will get into in a while. When we call for help, we need a senior obstetrician, a pediatrician, an anesthetist, and a senior nurse. We need to discontinue maternal pushing and avoid any lateral neck traction at this stage. The next step is to put a liberal mediolateral episiotomy because it increases the space, it increases the chances of delivering the anterior shoulder under the symphysis, and it provides greater access to the pelvis if additional maneuvers are required. It also protects the pelvic floor. The most important maneuver is putting the legs in the Mac-Roberts position, where the maternal hips are abducted, flexed, and rotated outwards. 2 assistants are required to maintain the position. It straightens the lumbosacral angle, rotates the symphysis superiorly with a relative increase in the anterior-posterior diameter of the pelvis. It is safe and effective in 90% cases in mild to moderate shoulder dystocia. Once the legs are in position, the maternal pushing and lateral neck traction can be commenced. Squatting achieves the same effect on the pelvis, but it is difficult to deliver in that position. All-force position is helpful, but again, difficult to achieve. The next important step is the suprapubic pressure, and it is very important to know how to give the suprapubic pressure. It's a lateral and downward suprapubic pressure with the flat of the hand against the anterior shoulder in Mac-Roberts position. The aim is to push the fetal shoulder into the oblique diameter to dislodge the shoulder from the symphysis. Also, this attacks the shoulders and reduces the fetal bisacromial diameter. The assistant may need to stand on a platform on the same side as the fetal spine. Initially, the pressure should be continuous, but if delivery is not accomplished after 30 seconds, a rocking motion should be used. The next one is enter the pelvis. We discontinue the maternal pushing and the neck traction. Attempt for an internal rotation of the anterior shoulder. Insert the hand into the posterior aspect of vagina and move it up to the posterior aspect of the anterior shoulder. The anterior shoulder is then pushed from behind into the oblique position. This is called a Rubin 2 maneuver. At this stage, it may be necessary to push the anterior shoulder back up into the pelvis slightly in order to accomplish the maneuver. After the attempt at rotation, we make a gentle neck traction and maternal pushing are recommenced. If that doesn't work, we enter the next maneuver, which is a Woods maneuver. Here we attempt the rotation of the posterior shoulder by 180 degrees. Push firmly on the posterior aspect of the posterior shoulder. Once the shoulder has rotated through 90 degrees, we change the hands in order to rotate the shoulders through a total of 180 degrees. This corkscrew maneuver disimpacts the shoulder from the pelvic inlet. Again, same as in Rubin's maneuver, it may be necessary to push the posterior shoulder back up into the pelvis slightly in order to accomplish the maneuver. And after the attempt at rotation, we make gentle neck traction and maternal pushing to see if it works. Now, if rotational maneuvers fail, we attempt to deliver the posterior shoulder. The right hand is inserted if the baby is facing the mother's left, or the left hand if the baby is facing to the right. The hand must be inserted into the posterior aspect of the vagina. The baby's posterior arm is flexed at the shoulder and elbow in an attempt to retrieve the hand or forearm. Try to grab the wrist. The forearm or the hand is then swept across the chest and face, allowing the posterior arm to deliver. The anterior shoulder will usually follow. This procedure may cause a fracture of the clavicle or humerus, but they usually heal well. This is a pictorial demonstration. Now, if this doesn't work, then we go to the other R, which is all force and try all over again, which is rollover, a symphysiotomy or a cleidotomy or a cephalic replacement. Now, cephalic replacement is not part of routine shoulder dystocia management or drill, and I have no personal experience of it. It involves application of constant firm pressure with the palm of the hand in order to flex the fetal head and return it to the pelvis, and the delivery is then completed by the cesarean section. This is known as the Zavanelli's maneuver with varying reports of success. It may be appropriate for bilateral shoulder dystocia, which fortunately is rare. The important issues are: do not waste time on a protracted attempt with one particular maneuver. Do not attempt inappropriate management like neck traction, maternal pushing, or fundal pressure. Excessive neck traction is the commonest cause of brachial plexus injury, especially Erb's palsy. And we know that shoulder dystocia is one of the commonest causes of high payout in negligence cases. Symphysiotomy is reported, but it requires experience. Now, if we look at the RCOG green top guideline, it puts the incidence of shoulder dystocia somewhere between 0.6 to 0.7% with a high perinatal mortality and morbidity. There is also increased maternal morbidity in the sense of because of PPH and third and fourth degree tears. The pre-labor warning signs of previous shoulder dystocia are macrosomia of more than 4.5 kilograms, diabetes mellitus, BMI of more than 30, and induction of labor. But as we said before, many shoulder dystocia cases would happen in completely normal labors. The intrapartum warning signs are a prolonged first stage, a secondary arrest, a prolonged second stage, oxytocin augmentation, and assisted vaginal delivery. An early induction of labor does not prevent shoulder dystocia in non-diabetic women, but it does prevent shoulder dystocia in women with diabetes. And in view of the Montgomery ruling in UK a few years back, it's possibly now mandatory to discuss the risk of shoulder dystocia in women with diabetes who plan a vaginal delivery. Elective cesarean should be considered in women with diabetes mellitus with an estimated fetal weight of more than 4.5 kilos. There are medical legal take-home points in shoulder dystocia as well, and it is important to conduct drill sessions with documentation of the drill sessions. As I said, in view of the Montgomery ruling, antenatal counseling of patients with diabetes mellitus, we need to maintain a partogram. Very important to have a systematic management and documentation. And in the documentation, we also mention what has not been done, like fundal pressure, lateral traction, and maternal pushing. There should be documentation of help sought and that it is managed according to local protocol and it is documented. We need to maintain a record of timeline with how much time each maneuver is taken, and that is why we need somebody in shoulder dystocia drill and needs to understand that there will be one person who will just be looking at the clock and taking notes. I will end with a poem. We are not sure who wrote this, but it is generally believed that it is by Hopwood in 1982. If shoulder dystocia brings you grief, oblique diameter spells relief. Extending episiotomy will be your boon to gain posterior vaginal room. If corkscrewing still leaves you colder, then gently deliver the posterior shoulder. Should the shoulder still fail to come away, consider the Zavanellis, for it might just save the day. Thank you.
Hi, my name is Gabriel Zenan. I'm from Brazil. For me, it's a pleasure to be here today to be speaking to you at the FIGO World Congress 2021. I would like to thank for the invitation to make part of these sections. I have nothing to disclose, and this class is going to be divided in two parts. The first one, I'm going to talk about amniotic fluid embolism, and the second part, I'm going to talk about thromboembolism. Amniotic fluid embolism is a rare but very potential lethal obstetric emergency. It's considered an unprediction condition, and its frequency goes around 2 to 6 cases per 100,000 births. Its mortality is pretty high. It can reach as high as 20 to 60%. It also has a related morbidity pretty much important that is related to neurologic hypoxia sequelae. Amniotic fluid embolism is an important cause of maternal death in high-income countries. Its pathology is not completely known, but we hypothesize that amniotic fluid enters into maternal circulations and it determines an abnormal maternal immune response, activating many inflammatory pathways and including activating the coagulation cascade. And the main impact it causes like an acute pulmonary hypertension that can lead to acute right ventricle failure and myocardial dysfunctions, and later on it will activate the coagulation cascade. The diagnosis of amniotic fluid embolism is a challenge, and it's based on clinical finds and exclusion of other potential causes. Amniotic fluid embolism triad it relies on acute hypoxia, hypertension, and coagulopathy in a pregnant woman during labor or delivery or right after delivery. There is no specific diagnostic laboratory test to either confirm or to refute amniotic fluid diagnosis routinely, but we have tried some before. And due to the difficulty of the diagnosis, many experts propose diagnostic criteria for the case definition of amniotic fluid embolism. And they defined 4 criteria. And all the patients should have all of these criteria to be included in a study of amniotic fluid embolism. And these criteria are sudden onset of cardiorespiratory arrest or both hypotension and respiratory compromise, the presence of coagulopathy that comes before the obstetric bleeding. We should also have a clinical onset during labor or within 30 minutes of delivery of the placenta, and this patient should show no fever during labor. And so whenever we have a patient like acute respiratory distress or even a maternal collapse, and we think that amniotic fluid can be the cause, we should go for its characteristics. So amniotic fluid has like a very marked hypotension, hypoxia, and coagulopathy. And it also is marked of the sudden onset. It has no prior fever and no recognized antecedents. And so this characteristic might differ it from the other cause. But whenever we have a cardiorespiratory collapse from a suspected amniotic embolism, the first thing we should do is immediately start a high quality CPR. But in pregnancy, it's important to do left lateral uterine displacement and remember to do a perimortem cesarean section using the rule of 4 minutes when we have like a patient still pregnant and we have a viable fetus. And when this patient is just returning of spontaneous circulations, we have to investigate and treat also an acute right ventricular failure because it can cause hemodynamic collapses. And also as part of this syndrome, we might have a coagulopathy, so we have to be prepared to do a massive transfusion in these patients. And even after all of this medical management, if the patient is still with a persistent hemodynamic instability, this patient might benefit from extracorporeal membrane oxygenation, known as ECMO. So from now on, we're getting for the second part of this class, and we're going to talk about thromboembolism in pregnancy. Thromboembolism in pregnancy is one of the leading causes of maternal mortality in high-income countries. Its prevalence goes from 0.5 to 2 cases per 1,000 pregnant women. Pregnancy is a risk factors for thromboembolism events, and mortality related to pulmonary embolism goes around 20 to 30%. But if we implement timely management of this, for this case, we can reduce it to less than 1%. And we also should highlight that this is a preventable condition, and we have a lot of protocols around the world with defined risk conditions with like well-established prophylaxis strategies. So we should always think about it and look for patients during pregnancy, delivery, and after delivery for these risk factors. The physiopathology of like thromboembolism in pregnancy start with like the visual triad. The visual triad is composed of stasis, hypercoagulability, and vascular damage. And the visual triad is predisposed for thrombus formation. In pregnancy, due to the anatomical and physiological change that we have, all of these 3 components are increased, and so these patients are more likely to form a thrombus. And whenever this thrombus is formed, it can detach from its organs and embolize to pulmonary circulation, causing in this case an obstruction in vasculature and determining a pulmonary hypertension. This pulmonary hypertension can lead to right ventricle failure and gas exchange dysfunctions. And if this disease progresses, it can cause a shock, and this patient can have hypotension, hemodynamic instability, respiratory failure, and maternal collapse. The diagnostic approach in pulmonary embolism is also not easy in pregnancy because many of the symptoms and signs of pulmonary embolism are inspecific in pregnancy. So we're going to look for like DVT signs, we're going to look for acute respiratory distress, dyspnea, tachypnea, tachycardia, and pleuritic chest pain. So the diagnostic combination should be made by a combination of clinical probability and test results. But we have to remember that all suspected patients with pulmonary embolism should start anticoagulation with heparins and start the evaluation, the investigations. So it's a pretty important, it's pretty lethal situation. We have to have like a very systematic and evidence-based approach to evaluate a pulmonary embolism. So now I'm going to show to you a structured method that use the minimum PQRSTU that might help us to diagnose and also to treat these patients. And it composed of 5 steps. The first step is the rule out criteria that's based in clinical assessment. Out of pregnancy, we have a lot of like scores that define if this patient has high or low risk of pulmonary embolism, but they were not designed for pregnant women, so they're not so useful during pregnancy. Also, but on the other hand, we might have a left rule that predicts deep venous thrombosis and can help us to define which patient will need compressed ultrasound. We also have the pregnancy adaptive use algorithm that uses 3 clinical criteria associated to the measurement of the dimers. This can rule out pulmonary embolism or they will define us which is going to be the next steps. And whenever we have assessed clinically, this patient is going to go to quantify the Gale stats phase, so to determine the proper use of other exams. We have a lot of algorithms, I'm going to show one of them. And these algorithms, that patient with suspicion of pulmonary embolism and deep venous thrombosis start with like doing a compression ultrasonography of lower limbs. If it's positive, we're going to treat this patient's heparin. But if it's negative, we're going to do a chest X-ray. If the chest X-ray is normal, we're going to prefer to use a perfusion scintigraph. But if it's abnormal, we would prefer rather computed tomograph pulmonary angiograph. And so coming back to the perfusion scintigraph, if it has like a high probability as a result, this patient should have received the treatment. If it has like low probability, we should look for other cause. And if it's inconclusive, we should go for a computed pulmonary angiograph. And so after that, we define like the risk stratification phase that determines the risk of this patient die due to the pulmonary embolism. This patient can be high risk, intermediate risk, or low risk. And so after we define that, we're going to go to the treatment phase. And in this treatment phase, all of the patients have to receive therapeutic anticoagulation with heparin for all, but high-risk patients with like a massive pulmonary embolism might benefit from thrombolytic therapy or other treatments like inferior vena cava, filters, percutaneous thrombectomy, and ECMO. And after that, we should decide where this patient is going to be managed. And patients with massive embolism should be managed in intensive care unit. To finalize, I would like to leave like key messages. Amniotic fluid embolism is a rare, unpredictable, and lethal condition if not managed promptly. Diagnosis based on clinical finding and exclusion of other causes. Prompt treatment relies on supportive measures. But thromboembolism has a higher prevalence in pregnancy, and it's preventable, so we should always assess patients for risk during pregnancy, delivery, and after delivery. So they can receive thromboprophylaxis in a general manner. And of course, we have to remember that prompt diagnosis and protocol-based treatment based on anticoagulations are essential to improve outcome and reduce maternal mortality. I would like to thank you for your attention.
So, thanks a lot to everybody of you for these excellent talks. We have so far no comments or questions from the audience, but I have some. Paulo, if I understood right, then you recommend oxytocin after carbetocin. I thought that the carbetocin has a stronger relation to the cells of the uterus, so that it should nearly senseless to give oxytocin after carbetocin. Is this was I not right so far?
Well, we use the carbetocin in the atonic status of the uterus.
Yes.
So because it's 100 times is stronger, so that's why we start with carbetocin when we have already the diagnosis.
Yes.
Or in the covalier uterus.
Yes.
That's why.
Okay, but you would recommend oxytocin after already given carbetocin, right?
Right.
Ah, yeah. Okay.
And
So,
at the first, as always, we try to do some massage or manual uterine compression,
yes.
and then oxytocin.
Okay. And what's about misoprostol and so on? You use it as well, but stepwise after. You would start with carbetocin, then give oxytocin, and then after massage and mechanicals, you would change to misoprostol, right?
Right.
Yes.
The problem with the misoprostol is that we usually in these conditions we're going to use it by rectal access,
yes.
and it takes a long time, maybe 30 to 45 minutes to act as uterine contraction.
Yeah. Do you in India and in Brazil have the same management of atone bleeding in the uterus?
Well,
do you hear me?
Okay, I'm sorry.
Is it the same management in India and in Brazil?
Well, actually, in Brazil, we don't have carbetocin, okay? And so we use like oxytocin, ergometrin, and after that, misoprostol, okay,
Yeah.
before you use balloon. So it's pretty similar to what they do in Mexico, at least the sequence of those measures.
We've just moved to carbetocin. Carbetocin has just been available for around 3 months in India, and our results with carbetocin are pretty good. I personally haven't come across a PPH after carbetocin as yet, but I have used only in around 20 odd patients. But if PPH happens, we would surely go on to syntocinon. I wouldn't use syntocinon just for prophylaxis once we give the carbetocin. But just like if you see, I'll not be worried about the receptors, because following an induction, long induction, when you used oxytocin, carbetocin still works. So similarly, after using carbetocin, if a patient is having PPH, I would still go ahead and use oxytocin as well as misoprostol.
Okay. Yeah, I really love here in Germany, we use carbetocin, I think, in most of the hospitals, and I think it's one of the best preventions for severe bleeding that was done in the last years. Yeah.
Also, another interesting observation is we find that after we move to carbetocin, our incidence of neonatal jaundice is reduced.
Okay. Yes, I have here questions how to train the doctors and midwives in thromboembolism and in amnion fluid embolism. Because these are so rare events, it's very hard to train, but maybe you can give us advice.
Okay, thank you for the question. It's pretty much important to train your team to manage amniotic fluid embolism and to diagnose thromboembolism, amniotic fluid embolism and thromboembolism, because they are pretty much rare. So in this situation, if you don't know what to think about, if you don't know that there is a possibility of having amniotic fluid embolism as a diagnosis, you're never going to diagnose that. So every patient that you have that goes to maternal collapse just around delivery, pretty much around delivery, just after delivery, we should always think about like amniotic fluid embolism. And the treatment of that, it's pretty much similar for treating a patient with maternal collapse. For the team, for the initial management, what we should know is how to do a CPR in a maternal collapse. And if you think about that, we have like to move on for like thinking about amniotic fluid embolism. And so if we do that, we should move for like trying to find if this patient develops like an acute right ventricle failure. And if it does, so we might need like a more wide team, so we can like have like clinicians, those intensivists and stuff like that to help us. So for us as an obstetrician, I think that the most important step is to know how to manage a CPR and to believe that like you might have amniotic fluid embolism in patients that goes to maternal collapse around delivery. And whenever we think about training, how to diagnose, I think that we should train the obstetrician how to diagnose thromboembolism more than like how to manage it, because like the most difficult thing we have, like the people believe that this patient has thromboembolism. They think in a lot of things, but sometimes they don't think in thromboembolism. What it's pretty much weird, because it's not so rare. And if you start treatment pretty soon, you might have a very good results. Usually, of course, you don't have like those massive thromboembolism. So I believe that we should train our team to diagnose thromboembolism and how to manage how to do a CPR in a mother that goes into collapse. I believe that this is the most important treatment. And remember, if you think in thromboembolism, you should treat with heparin. Today, with like the COVID-19, at the very beginning, many times we treated the patients like a thromboembolism because we did not know that there was about COVID-19 or if that was thromboembolism. So it's why sometimes we see some people treating patients that they seems to be COVID, okay, but because like the differential diagnosis was thromboembolism. So after that, they stopped the heparin if the patient did not have criteria for using it due to the COVID. 19.
And do you have, I think data will not be, but do you have own experience how in how many minutes or half an hour or what time line does it take to elevate the right maternal ventricle? Because I think in nearly every obstetric hospital there are ultrasound possibilities. So would you recommend to take a ultrasound just to make this diagnosis, or is it too? Will it take more time?
What about the deep? Sorry, about you're talking about the deep thrombosis, or about like the
the amnion fluid embolism.
Well, actually, the diagnosis of like maternal collapse should be immediately, and so we should start CPR immediately. And whenever this patient returns from the collapse, she just like returns, we should try to do like a transesophageal exam. That's what's recommended, but it's not so easy. I don't know how it's in German, but like in Brazil, sometimes it's difficult to have the specialist to do that, because it's not everyone who is I can say it that is capable to do this exam. So one problem that we have is like to have this person to do like this transesophageal exam for us.
And do you?
I'm gonna call them.
Yeah, and one question to the compression. This is a question to Paulo. This model of compression you showed us, is it just for the transport or just in a hospital to stabilize the pregnant or not more pregnant mother?
No, it's in the hospital. Usually it's in the transoperatory. And we use this, we change this technique, not using the hand, because we have to do a lot of pressure, like 25 kilograms. And when you put the hand inside the abdominal cavity, you use a lot of the space, and you use, so that's why we use that instrument, just to do easier the compression, and we don't use so many space in the operatory campus. So it's easy for us, and we can change the person that is doing the compression, because we have to do a lot of compression to stop the blood flow from the abdominal aorta to the iliac arteries.
Yeah,
it's just temporary, just to stop the loss of bleeding of blood, please.
Yeah. Then I have a question about shoulder dystocia. Do you recommend maybe a cesarean not only when the estimated weight of the baby is over 4.5 kilogram, but when if there is a big difference between in ultrasound diagnosed, we all know the pitfalls of ultrasound, but diagnosed circumference of the abdomen of the baby when it's much more than the head circumference? And if yes, how many centimeters are the cutoff for you?
We wouldn't go by that, actually, because unless you go through a trial, you'll never know how it will be. But I think as far as the baby's weight is concerned, I think the counseling would be different if the patient is having a gestational diabetes and the patient is not having a gestational diabetes. So especially in view of the Montgomery ruling, we need to discuss about the implications of shoulder dystocia. And the problem with shoulder dystocia is that if it is a unilateral shoulder dystocia and it comes with just a McRoberts maneuver and suprapubic pressure and just trying to deliver, it's great. Once you have to get into the maneuvers, your outcome is not necessarily always very good. So I have a feeling that a big baby with gestational diabetes very often patients would opt for a cesarean section. But if the patient is not diabetic, I wouldn't really be worried that much, and we'll see how the progress of the labor goes. If the labor moves quickly, I wouldn't be too worried. But especially if it's a secondary arrest, rather than pushing it through, it may be reasonable to resort to an early cesarean at that stage.
Thanks. We have one more question here from the audience. What is the reason not to give ergotamine in the situation after abruptio placentae?
That's why the ergotamine is a very strong vasoconstriction medication, and we stop the flow from the flow to the myometrium and the myometrium cells. That's if it happens, the myometrium cells can be damaged, and it's probably it won't respond to the oxytocics pharmacs.
Okay.
That's why.
So thanks a lot again to everybody of you, and thanks to the audience. It was a very interesting and I think a very, very important session here in the FIGO Congress. Thanks a lot for your engaged talks, and because we are all separated all over the world here in this round, I hope you have some nice following hours during night or daytime, depending where we are just in the moment. And see you again, caring for women and babies all over the world. Thanks a lot.
Thanks a lot.
Thank you.
Thanks for the invitation.